So thank you very much, Simona. Thank you for your presentation and for inviting me here, and thank you to all the organizing committee. It is a pleasure for me to be finally here with you, because we met virtually in some editions of your Congress, but finally we are able to see each other. And really it is a different story when we can meet. So it is my pleasure today to discuss with you about the new update of the EULAR recommendations for the management of lupus. But I have to tell you that the official paper, has not been published yet in the Annals of Rheumatic Diseases. So I had the paper. I was part of the group developing the recommendations, but I need to ask you not to take pictures because it is not published yet. So I will base my presentation on what I know and what has been presented at EULAR. So these are my disclosures. So I would like, before really entering into the topic, to follow a story, and it is the story of lupus and of the management of lupus. And a few years ago, I discussed with a colleague, and we were discussing about the difficult to treat. We have difficult to treat rheumatoid, we have difficult to treat everything. And I said, okay, we should do some difficult to treat lupus. And this colleague, he's not a lupus person, told me, because there is an easy to treat lupus. He made me thinking, and in fact, this is why I prepared this slide today. Lupus is difficult. Lupus is a difficult disease. And why is it so? Well, because lupus starts, and we will see in a very strange way, sometimes it starts as an undifferentiated disease, so we really do not know what we are dealing with, and the diagnosis is delayed. Lupus is the great mimicker. The clinical picture of lupus is really very heterogeneous, so that we wonder whether lupus is one disease or not. And we expect everything from a patient with lupus. So when a patient is diagnosed with lupus, it is lupus. In any case, whatever it is lupus, because we expect this disease to do different things. So when we treat lupus, we need to think about multiple targets. So we need to think about disease activity. It is true, but now we know that it is not enough. When we treat lupus, we do not go to treat disease activity. We need to keep in mind damage accrual. We need to keep in mind comorbidities and drug toxicity. And we need to keep in mind quality of life, as a benefit of a treatment is reflected by the way the patient feels the benefit, the way the patient survives, and the way the patient is doing the life activities. Until recently, there were few trials, and in lupus we know that there were trials in lupus nephritis, but in non-renal lupus we had very few randomized controlled trials. So it was also difficult to treat lupus because we have used a trial and error approach in choosing the treatments that we've been using. Now we know that methotrexate works for arthritis and skin disease, but no clear data were available to do so. So indeed, treating lupus is not an easy task. And this is reflected by the fact that when we go into clinical practice, we use our experience and our knowledge, how many patients we have seen, and we have to admit that if we do so, then we have variability. Even in the same clinic, we do not treat patients in the same way if we do the way we want to do this, if we do not follow a guideline or a clinical practice guideline on a recommendation. So if we do and manage this difficult disease this way, what happens is that we have variability, but we also have poor outcomes because we are really moving in a confused way. And by the way, this is something the ERN are working against, because with the ERN, we really want to implement recommendations and give good quality of care to all our patients. So this is really my first step towards the discussion, towards how we can improve outcomes. And if we look at the patient management, the development of recommendations, quality indicators, the treat-to-target approach are one of the ways to improve the management and the outcome of our patients. Again, we could think that the best way would be to have a new treatment, but we need to know how and when the new treatment should be used. So we need guidelines so that we homogenize the way we treat our patients. So that's why there is this business of recommendations. And in lupus, the business started more or less around 2009. We all know these old recommendations. These are the first recommendations on the management of lupus and are old recommendations, but were really a big, big step ahead. In these recommendations, some points on treatment were raised, how the fact that lupus is a complex disease should be treated, taking into consideration different aspects in a multidisciplinary way was discussed. And I have to say this was the very first time this was done. So these recommendations were not really guiding us into how to treat lupus, but were guiding us in the management, in the concept of the complexity of this disease. So here you can see that it is actually stated that we should use for lupus antimalarials and glucocorticoids. Non-steroidal anti-inflammatory drugs are mentioned here. And then in non-responsive patients, the concept of considering the use of immunosuppressive drug is raised. So today it is use immunosuppressive drugs. So really, really things have changed. And obviously, there were recommendations on how to manage lupus nephritis. And at that stage, we were at the concept whether cyclophosphamide or mycophenolate should be used. But things moved on. Things moved on for many reasons, because we wanted more, and we started to have also new treatments. So new treatments raised new questions and new opportunities. And so I think that the second step were the treat-to-target recommendations in systemic lupus. Treat-to-target recommendations, obviously I'm out of my topic, were really setting us the scene on how to follow patients and telling us activity, damage, glucocorticoid, and so on and so forth in the treatment of lupus should be considered. But to me, one of the greatest messages of the treat-to-target recommendations is one of the overarching principles. Treatment of lupus should aim at ensuring long-term survival, preventing organ damage, and optimizing quality of life. And this is done through a control of disease activity, a minimization of comorbidities, and of drug toxicity. So we move a little bit further, and we open and we clearly state this concept. Well, what is disease activity? How we measure disease activity? What level of disease activity is acceptable in patients with lupus? Well, the treat-to-target recommendations have opened the door to the definition of remission and lupus low disease activity state in lupus. So now we do have targets. We know that we have to aim at something when we treat our patients with lupus. Following these definitions, a lot of literature has been produced showing that if we put our patients in LLDAS, even better in remission, we have better outcomes. And so this has been taken in the 2019 recommendations on the management of lupus. And I would consider this as a big change, and the 2023 build on these recommendations. And we all know this, because this has been largely used. This is the scheme we should have on our agendas, on our table in the clinic, because this is the guidance on how to manage patients with lupus. The target, first of all, remission and lupus low disease activity state. The adjunct therapy is not just treatment, it's also sun protection, smoke avoidance, vaccination, for example, and the treatment. And what you can see here, you can see that we use hydroxychloroquine, we use glucocorticoids, and then you see the colors, and the only green color is belimumab. At that stage, this was the only treatment for non-renal lupus studied with randomized controlled trials. So that's the reason why belimumab was included in recommendations and was green. So here, I'm just pointing out a few of these concepts because the great changes are reflected then in the 2023 recommendations. In the 2019 recommendations, there was an advice to use very low doses of glucocorticoids, going from the treat to target and from the knowledge that glucocorticoids induce damage. At that stage, the suggested dose for maintenance therapy was 7.5 milligrams of prednisone per day. So as you see, if possible, withdraw, but you should go below at this dose or below this dose, which, by the way, is the dose suggested in the LLDAS definition. The immunosuppressive therapies are strongly suggested in those patients who have persistently active disease, flaring, who cannot be controlled with low doses of glucocorticoids. So this is a change. Use immunosuppressive drugs early when you realize that you are not able to control the disease. Do not use glucocorticoids, but add an immunosuppressive drug. And there was a different recommendations for biologics at that time. So we had different points: glucocorticoids, immunosuppressive drugs, and biologic treatments, where we suggested that biologics could be added in the treatment of patients with lupus, in which, again, with or without immunosuppressive drugs, the disease activity could not be controlled in a proper way. There were also recommendations on skin disease, and even though we have EULAR recommendations for lupus nephritis, recommendations for renal disease were also into this paper, into this work. And again, mycophenolate and cyclophosphamide low dose were suggested as induction therapy, induction of remission. And obviously, the idea of switching from one to the other in the case the patient was not responding, and the maintenance was based on mycophenolate and azathioprine. We had the maintained trial data from the EUROLUPUS trial. But many things happened between 2019 and 2023. I think these have been incredible years for many, many reasons. Obviously, I mean, we still wear masks when we are in some places, and our life has changed due to COVID. But over these years, in spite of COVID, we've learned lots of things. And I've added some information here. Targets. We continued to evaluate the targets. And now we have, in 2021, a final definition of remission for lupus. And we know, it's clear from different cohorts, that LLDAS and remission are achievable and are meaningful targets. There have been lots of papers published on glucocorticoids, particularly on steroid withdrawal, which I would say is an achievable target. And we have new treatments, because now we do have belimumab. On belimumab, we have accrued so many data on real life. We know a lot about belimumab. It's not a new baby on the block, actually, because there is a new baby. It's anifrolumab. And anifrolumab was approved in 2021, actually. In Italy, we have had anifrolumab for a year and a half now, but officially it's just a few months. But it's not just this. We have the BLISS-LN study, so the data on the use of belimumab for lupus nephritis, and voclosporin was again approved for the treatment of lupus nephritis. So the 2019 recommendations guiding us through the treatment of lupus needed an update. So these were presented at EULAR in Milano, and I'm not going through all these. I have 15 minutes. These are many, many recommendations. I would like to highlight the changes between 2019 and 2023, and particularly those changes that, to my view, are the most important ones. So I will discuss a little bit about a few overarching principles: glucocorticoids, the early immunosuppressive therapy, and lupus nephritis. So, as always, we have overarching principles in these recommendations. The structure has been changed. Some recommendations, when you will read the paper, have been let's say, condensed into one. But I would like to put your attention on number 2. SLE disease activity should be assessed at each clinic visit with evaluation of organ damage at least annually using validated instruments. So, I'm a rheumatologist, I'm not a lupologist. I do rheumatoid arthritis, and I measure. And I imagine that measuring now for rheumatoid is routine. But when I go and speak about lupus and I say, you should use SLE dye, you should use the damage index, you know what the majority of people tell me? Oh, it's time consuming. Well, it is not. It is a matter of learning and doing. So the advice is that we measure, because we need to have objective measures to understand what's going on. But please remember that anytime you see a patient with lupus, you need to consider damage. And an emphasis on damage is now there. Why? Because damage brings bad prognosis, but now we can prevent damage. So, I mean, in an era where lupus was treated with glucocorticoids, we could not. We had to accept damage. But now we do have drugs that allow to reduce damage accrual in lupus. So we need to see whether we are reaching this target in our patients. And the reason, as I'm showing in this slide, is that damage brings further damage, decreased quality of life, obviously decreased work productivity, and most of all, early mortality for our patients. We know that organ damage in lupus is likely to develop very early. So it is not a story that we need to realize after 5 or 6 years. We need to think about damage since the beginning and evaluate whether we are successful in preventing damage. This is our cohort in PISA. We follow more than 500 patients. I'm showing to you the data from 450 patients, and you can see that in our cohort, half of our patients have damage. And if you see the disease-related damage, you can see that at 1 year, 10% of our patients have damage, and at 1 year, many of these patients have disease-related damage. This is a long-term disease cohort, it's not the inception cohorts. So it reflects the past, but it's from the past that we have to build a better care for the future. And as you can see, we have lots of patients, for example, with renal damage, so it's really an unmet need. The second overarching principle I would like to put your attention on is the fifth, early diagnosis. We need to advocate for early diagnosis of lupus. We need to work with GPs, with the health system, for the early diagnosis. Why is early diagnosis so important? It is so important because, you see, there is a delay in lupus diagnosis. These are data from UK, and you can see that in some cases, it took 4 years to diagnose lupus. This is the pathway in Greece for patients with lupus. This is a paper published by Dimitri Boumpas and George Bertsias. It is a very interesting paper where they show the pathway of patients before diagnosis. It's really long, and the majority of patients reach a diagnosis after many consultations, at least 3. Half of the patients were diagnosed late. Early diagnosis is defined within 6 months from the onset of manifestations. But why it is important? Well, because of this. Patients with late diagnosis, so over 6 months, 6 months is nothing, they do have damage. So it is very important in respect with damage not to lose a window of opportunity to treat our patients with lupus. So I think that this is a new concept, a window of opportunity, because data show that we do have a window of opportunity to early diagnose our patients and to prevent damage. And we have seen together how damage impacts on our patients. And so these are the new, do not take pictures, please, because this is really unpublished. These are the new 2023 recommendations, and you can immediately see that there are a few changes there. The first change refers to glucocorticoids. It is not anymore 7.5. You need to go to 5 milligrams of prednisone. So even if the patient is in LL-DAS, because we may discuss this, and LL-DAS is 7.5, no good. You need to go to 5. There is no safe dose of glucocorticoids, I have to say. The lower the better. The recommendations tell you 7.5 every day is not good. So we need to maintain no more than 5, but then another recommendation is telling us you need to stop, if possible. So I think that this is a very powerful recommendation for us, because we then have to develop a strategy to do so. And why? Well, I'm just saying very rapidly, we all know that glucocorticoids are responsible for damage very early. So glucocorticoids, immune suppressive drugs, you see, these are data accrued over decades. So glucocorticoids are not good, well, are good, have changed the story of lupus, but should not be the treatment for lupus. We should use glucocorticoids when in need for very active disease. And if we taper steroids, we have a great advantage. These data show that there is no safe dose, but if you go below 7.5, each milligram day that is spared is a reduction of future damage. So it makes sense even 1 milligram per day, 365 milligrams per year. Is it easy? No, it is not easy. If we go into the literature, there are data that I told you, and these are the data on which this recommendation was based, showing that it is difficult to taper and stop steroids. There is this very scaring trial run by a French group telling us that when you taper steroids, 27% of patients who have stopped steroids have flared. So very scary. They were fine, now they're flaring. We lose all the work that we have done. But my point of view is not that we should not stop steroid. We should identify those patients in which steroid withdrawal is possible. So that is what we have done with our cohort. And I would like just to tell you that in our cohort, we were able to stop steroids without flares in those patients who actually had a long-term remission or low disease activity. So the patients need to be very well for some time before you start stopping steroids. So we want to stop steroids. We want to take an opportunity of the window of opportunity of early treatment. How do we do this? Well, with hydroxychloroquine, for sure. With glucocorticoids, the less, the better. But when needed is needed. So you use the dose you need, but then you taper, and if possible, you withdraw, and then you add an immune suppressive drug. So there is a recommendation that now puts together immune suppressive drugs and biological drugs and tells you that if you're not able to control disease activity and you're not able to taper steroids, then you add an immune suppressive drug or anifrolumab or belimumab. This means that you may want to add belimumab or anifrolumab after hydroxychloroquine. Yes, there was a lot of discussion around this. In Italy, personally, I don't do this. I add immediately belimumab. I've added immediately belimumab in very selected cases. Usually, I use a traditional immune suppressive drug, and after the failure of the first one, then I add on a biological. But why these drugs are together? Because the data of the literature tell us that they are at the same level, if not better, because belimumab and anifrolumab are green. We have randomized controlled trials. But obviously here we face the availability, we face costs, and our responsibility is to respect our healthcare system so that it is affordable and we can treat all the patients. So I think that this is an important point, but consider these data support the early use of these drugs. Here, I would just very briefly show you the data with Benlysta, showing to you that indeed Benlysta supports in the achievement of our targets, lupus disease activity and remission. And here you see that these patients have less flares than those patients who have received a placebo. Here you see all the data that I told you have now from the literature on the use of belimumab, either from randomized controlled trials, but also from real-world evidence. Glucocorticoids go down when you use Benlysta, so for sure this is the target we want. We don't have all this data, unfortunately, for traditional drugs, and particularly all those patients who were above 7.5, many of them were able to go below, so it's very important. And this means less damage. If we go to anifrolumab, we have data from the randomized control trials and the long extension trial. And again, you can see that adding anifrolumab to standard of care in patients with mild to severe lupus was able to control disease activity. I find this really amazing because this was done by tapering steroids, what we do in our real life. I add the treatment, I wait a little bit, the treatment action, and then I taper steroids. And this was actually shown in the randomized in TULIP-1 and TULIP-2 trials, together with a great reduction of skin involvement. If we go to the organ manifestations that respond very well to anifrolumab, well, we are not amazed when we see that it's musculoskeletal and mucocutaneous disease. I will move on just to show you the tapering of steroids together with the improvement of disease activity for the CLASI response for the skin manifestations of anifrolumab. And just to share you one of the patients we have treated in the clinic, you see before and after a patient with severe discoid lupus treated with anifrolumab. And I have to tell you that these results were obtained in 4 weeks. And now we move to lupus nephritis, because lupus nephritis is the other very important point. Many things have changed. We still use cyclophosphamide and mycophenolate in the induction, but the recommendation is telling us something that we were expecting, that it is strongly suggested that we do a multi-targeted therapy in the treatment of lupus nephritis. Lupus nephritis is a severe organ involvement in lupus. And since the beginning, we shouldn't wait, because if we wait, we lose nephrons. And if we lose nephrons, then this is bad for a young lady with lupus. So what could we do? Well, now we know that adding either belimumab or voclosporin to mycophenolate or mycophenolate and cyclophosphamide for belimumab helps in obtaining better outcomes. We do have the data from the BLISS-LN study, 2 years study, showing that adding belimumab on top of cyclophosphamide or mycophenolate gives an advantage as far as renal endpoints are concerned, as far as renal flares and kidney-related events are concerned. As you can see here, there is a reduction of lupus nephritis flares, so that's what we want. So we maintain kidney function and we reduce flares. And we have data on voclosporin. This is a very interesting 52 weeks trial in which lupus nephritis was treated with very little dose of steroids and on top of mycophenolate. So in summary, what could we say? That lupus is difficult, and our new recommendations tell us that we need to focus on early diagnosis. Early diagnosis is one of the keys today of the treatment of lupus, because with early diagnosis, we do not lose opportunities in treating our patients. We need to prevent damage. We need to prevent damage, and this can be done by controlling disease activity and minimizing the use of glucocorticoids. So, a more restricted use of glucocorticoids is recommended in 2023 recommendations. Aim at 5. Use the dose you have to use. You want to pulse with 1 gram, pulse with 1 gram. But remember that you have to go to 5. If you cannot go to 5, use as early as possible an immune suppressive drug. And if you have availability, based on your experience, consider also the possibility of biological treatments as we have data. So I would say that the take-home message is not use anifrolumab or belimumab in an early disease, because we still do not have many data, but use an immune suppressive drug, including those, not after 2 or 3 years. It would be a pity for your patient. Anifrolumab and belimumab have different mechanisms of action. They have not been directly compared. Maybe another time we will discuss how I choose one instead of the other. I really have to make up my mind on this. But for sure, we also know that we can early combine, and this is suggested, voclosporin or belimumab to standard of care for lupus nephritis. I would say that this cannot be mandatory in a recommendation, but is really strongly advised. We discussed a lot about the strength of these recommendations. And with this, perfectly on time, I hope, I thank you for your attention.